Before I continue on this page, I just want to note that in talking about my own personal vitamin C usage, um, it's very important that you spread those doses out over the course of the day. It's unlikely that your body can absorb more than 1 gram per hour. If you're sick, your body does immediately alter its ability to absorb vitamin C, and it will absorb greater amounts of vitamin C given the greater need for vitamin C. But on the normal healthy person, 1 gram per hour is a kind of a maximum amount. If you do end up taking more than your body can handle, you may find some case of diarrhea at some point. That is definitely a common symptom of too much vitamin C, more than your system can handle. I don't find any problems at the 8 to 10 grams a day I take, although I am a heavy person. So your maximum dose might be less, in the range of 5 to 10, somewhere in there. And moving forward, at the main website here of the Frontline COVID-19 Critical Care Alliance, you'll see on the homepage, see our video, meet our doctors. You can obviously choose either of those. You can pause and read this if you'd like. This link is to the page I was showing you previously. And also, there's a nice link here about preventing COVID-19, and you'll also find more information that we covered earlier. But no doubt, feel free to pause and take a minute to review the information here. I want to note, when you click on the video, you notice that it says the components of Math Plus, meaning the protocol, are off patent, correct myself there, off patent, inexpensive, and globally available. So if we know that Math Plus works, produces fewer side effects, and saves lives that would otherwise be lost, such as the 120,000 lost lives in America so far, why isn't it being used throughout the world? And that's a serious question. Why is this protocol not used in every hospital? You would think that it would be used universally. Well, here's the answer to that. Math Plus COVID-19 Early Intervention Protocol. We know that our math protocol works and saves lives, many lives. Here's the backstory about why it is not yet been widely adopted. Tragically, the World Health Organization ignored extensive evidence in recommending against the use of corticosteroids in COVID-19 ARDS and cytokine storm. Neither the WHO nor other guideline-writing bodies have assessed the formidable and growing evidence of intravenous ascorbic acid. Despite its association in major recent studies with significantly improved mortality in ARDS, numerous previous studies have also shown its safety and effectiveness, particularly when used with corticosteroids in critical care medicine. Physicians at the bedside of critically ill COVID-19 patients are told to provide only supportive care and to enroll their patients in one or more of hundreds of randomly controlled trials, often testing one or more of a growing list of expensive and proprietary formulations, where half of the patients receive a placebo. And this is why I'm making this video, because this is what we're doing. We're currently using COVID-19 patients as guinea pigs to test our expensive, exotic designer drugs. Well, that's if you're lucky. The other half of the people get no treatment. These RTCs, clinical trials, are exceedingly difficult, if not impossible, to design to assess interventions that need to be given within a very short number of hours after the deterioration of the patient, as is the case with COVID-19. And they are fraught with methodological and ethical barriers. Boy, we do have some ethical problems here. Worse yet, the result of RTCs in COVID-19 will take weeks or months to provide feedback to gain improvement of treatment protocols. During that time, lives will be lost. They could be saved with the Math Plus protocol. Meanwhile, well-designed, large observational studies could be done and provide timely information to improve the treatment protocol. Math Plus uses well-studied, life-saving components used synergistically that hospital-based and critical care doctors have been using for decades. It should be the foundation upon which other interventions are added and not excluded from the armamentarium of physicians at the bedside. COVID-19 is a steroid and ascorbic acid responsive disease, meaning we know this stuff works, okay? There's no question. Math Plus has our 100% endorsement because our only obligation is to save lives of our patients. Their goal is not like the rest of the world who's trying to make billions of dollars off of a designer drug they can call a COVID-19 cure or a COVID-19 treatment. This is the plan. So many people have to die and not receive this treatment so that somebody can make billions off of a proven designer drug. Oh boy. That's what we will continue to do using Math Plus, saving lives. The most powerful and effective treatment available for critically ill patients with COVID-19. We are working hard to share our knowledge with hospitals, physicians, and nurses around the world in order to save countless thousands of lives that could otherwise be lost in this epidemic. It's just overwhelmingly disturbing that our system is what it is. I want to click over to this page here, and I'm going to show you how to get there. Okay, when you're on the main website for COVID-19 criticalcare.com, you want to go over here to medical evidence, and when you click on that, it immediately opens up a menu here for the methylprednisolone. That's the anti-inflammatory that is the first part of the protocol. When you close that, you can see all 5 protocols here. And when you open each of these, you'll see, anywhere from 10 to 15 documents, which are all medical papers and other types of documents related to that particular step of the treatment plan. That would be for the additional vitamins and, just clicking on the one for ascorbic acid or vitamin C. There is where you'll find the document that I'm showing on that other tab. But nevertheless, this page is crucial to you doing your own research, as here, this organization has clearly laid out all the research and documentation on why these 5 steps treat COVID-19 so successfully. But one of those documents that I happen to pop open here, it talks about quercetin and vitamin C as a combined therapy. This quercetin is also something you can buy off the shelf when you pick up your vitamin C. And it's got quite a history if you read about it. But this goes on to say, severe acute respiratory syndrome coronavirus represents an emerging global threat which is straining worldwide healthcare capacity. As of May 27th, the disease caused by SARS-CoV-19 has resulted in more than 340,000 deaths worldwide, with 100,000 deaths in the U.S. alone. It is imperative to study and develop pharmacological treatments suitable for the prevention and treatment of COVID-19. Ascorbic acid is a crucial vitamin necessary for the correct functioning of the immune system. It plays a role in stress response and has shown promising results when administered to the critically ill. Quercetin is a well-known flavonoid whose antiviral properties have been investigated in numerous studies. There is evidence that vitamin C and quercetin co-administration exerts a synergistic antiviral action due to overlapping antiviral and immunomodulatory properties and the capacity of ascorbic to recycle quercetin. Again, they work synergistically, so the capacity of the vitamin C to recycle the quercetin, increasing its efficiency. Safe, cheap interventions which have a sound biological rationale should be prioritized for experimental use in the current context of a global health pandemic. We present the current evidence for the use of vitamin C and quercetin both for prophylaxis in high-risk populations and for the treatment of COVID-19 patients as an adjunct to promising pharmacological agents such as remdesivir or convalescent plasma. But there you go. They're telling you quite clearly the prophylactic nature. This vitamin C regimen can easily prevent COVID-19 as well as get you back together and home safely and healthy. This information is just overwhelming. I think I'm going to close my video by actually playing the video that's posted on the website. We're going to go back to home here, and we're going to watch the video together because there's some really interesting information in here, including one particular doctor that's been treating COVID patients with this treatment protocol that clearly states he's had 0 fatalities. Go figure.
Hello, everyone. This is Dr. Howard Kornfeld. I'm a board-certified emergency physician. I have been honored to, in the last several weeks, meet some of the top critical care specialists working on the front line of the COVID crisis. These are innovative doctors who have recognized that the standard protocols are not working. As we could see in New York, it's a disaster, and that disaster is coming to other cities. So I was thinking of asking Pierre Corey to maybe introduce the subject further to help explain why this incredibly powerful treatment, which all of you are providing, is not being provided, and how we can help change this situation very, very quickly.
Yes, when we talk about the therapy, I mean, there's a few therapies that we have in mind, but I would say that the core and the most powerful of them would be the use of corticosteroids in combination with intravenous ascorbic acid. This is hospital grade, intravenously delivered, but we deliver it at relatively high doses, and we maintain those concentrations in the blood by giving it every 6 hours. And it works synergistically with the steroids, and we found many people have reported, I think all of us on this panel have published or done research or reported our results using those the two main drugs in combination in critical illness states, especially in severe infections and septic shock. Whenever you make a strong claim around a vitamin, I think most people, most doctors are very conservative and skeptical of such claims, and so it's very hard for most physicians to adopt the therapy fully. In critical care, we have achieved dramatic reductions in morbidity and mortality, largely around mechanical ventilation, judicious use of fluids and different antibacterials, and we have these great outcomes. But here comes COVID, and what's happening here is the crisis is that I think we're not starting effective treatment early enough and aggressively enough. And as a result of that failure, our ICUs are filling, our ventilators are running out. We're now forced to devise these ingenious ways of splitting ventilators to ventilate multiple patients. And one of the core principles of critical care that we might be forgetting is that time is of the essence. You need we call it the golden hour of resuscitation. So as soon as someone falls ill, that's when the intervention needs to be started. And I think the answer is actually not in the ICUs. I think by the time they get to doctors like us on this panel, we're going to struggle, even with the powers that we have with these therapies working synergistically. My appeal is to the doctors out on the front lines, the doctors who are first laying eyeballs on them in the wards, that we have to change our strategy here. It's not working.
I'll be right back.
Just a few points with reference to COVID. So I think it's really important to treat patients for the disease they have and not for the disease we want to give them or we think they have. So there are really three fundamental concepts. Firstly, this is not typical ARDS. And if you intubate them early and put them on a ventilator, you're going to damage their lungs. You're going to harm them. Number two, this is a profound hyperinflammatory state. They have these ground glass opacities, which is inflammation, not fluid. And you need to give anti-inflammatory drugs. This is not the virus that's hurting the host. It's the acute inflammatory dysregulated response. That's why you need to use vitamin C and steroids. Steroids play a critical role in the synergy between vitamin C. The third point is these patients come in with a profound hypercoagulable state, which is somewhat unique to COVID. So we believe that you need to anticoagulate them up front. And indeed, if you look at the Shanghai guideline, they did two things or three things. I mean, it's truly remarkable, and I didn't appreciate it when I first read it. They gave heparin, they gave vitamin C, and they gave steroids. So that's the first point. The second is you need to treat these people early. Titanic is already sinking. You have to intervene early and aggressively to prevent them deteriorating. And in this way, you can prevent them landing up on the ventilator, which is actually harmful.
Having seen what vitamin C could do, I decided to start giving vitamin C very early. But let's say you're a patient that comes to me with shortness of breath and an abnormal CT scan, like the ones that have circulated among some of us. And that is the moment when I do my intermediate unit, and I start on the tail. And we've had several variations of what we have done for the cockpit. I have not had a single death, not one death. And I'm getting slammed with 4 to 5 admissions per unit minimum. I mean, you don't need to sell me the vitamin C thing. I mean, I know it works.
Yeah, what I'm hearing is that in these 24 patients, using Dr. Merrick's protocol, essentially, with some variation, you have had no deaths. Is that correct?
That's exactly what I'm saying.
Yeah.
You started early, patients will they don't even need to be intubated.
Vitamin C had a profound effect, and clearly there's a synergistic effect with the use of corticosteroids. Therapy early is of the utmost importance. This is these patients start getting very inflamed by about 5 or 6, and because the ERs are already congested, they're coming in at that time period to where the point they're going to get that subgroup of patients, that endotype of patients that has that coagulopathic and inflammatory response is going to be there, and then probably earlier treatment is when you're going to start seeing a better effect.
The corticosteroids work in viral pneumonia. Well, there are 2 large studies in patients with SARS, more than 5,000 patients. And there is another large study in patients with A1N1, all from the Chinese literature, indicating that the use of methylprednisolone, that is the one recommended by the task force of the Society of Critical Care Medicine, Intensive Care Medicine from Europe, is associated with a significant reduction. The reduction in mortality was 50%. The protocol for steroids has been recommended by the Chinese, Korean, Japanese, and Italian society. So it is already a part of the guidelines there.
That all the physicians are making is really early treatment. A lot of the thoughts before was to start once they get to the ICU. But what we're now finding, because the ICUs is now being overwhelmed, is to start as soon as they come into the emergency room. As soon as they're identified with COVID-19, able to start that treatment within that first 6-hour time window, we can prevent a lot of these people from ending up in the ICUs. And know that we're actually down to less than 15% capacity for ICU beds in New York City.
When we talk about early treatment, we have to recognize that many centers around the country have long turnaround times for tests. I would say in any high clinical suspicion of COVID, it should be started. What it really is a life-saving therapy. And it's actually been proven to be life-saving in the condition that is killing the world. The condition called acute respiratory distress syndrome. The patients are dying of overwhelming inflammation. We need to marshal our therapies that are directed at suppressing that inflammation. It's key to keeping these patients alive.
I think that the patients coming in already to the ER have selected themselves out in one major direction, and particularly in that pulmonary findings. They are clearly most likely of a pro-inflammatory and coagulopathic genetic endotype, that a large percentage of them will end up very ill very quickly. They've already been at home sick for several days, so they're already at that time point where they're at that kind of hill before they go downhill, and that's when we should treat them from the emergency room.
The common denominator in these 5 physicians who are at the front lines, critical care units, watching or actually ordering the drugs themselves, is that intravenous vitamin C, intravenous ascorbic acid, along with corticosteroids, given at the right time, not for mild illness. This is for when the oxygen is dropping, the virus is essentially taking over the lungs. A massive inflammatory response is occurring, and it needs to be done extremely expeditiously within hours, if possible, of presentation to emergency rooms. This, as far as we understand, is not what's being done in a widespread way yet in the United States.
I think patients are dying needlessly, and I think this is a terrible shame that we're allowing this to happen. It is an outright shame. We have effective therapies that can alter the course of the disease. We need to institute them early, aggressively, and we need to prevent patients deteriorating and landing on a ventilator. Once they land on a ventilator, we know their course is prolonged. The mortality may be up to 60 to 70%. It takes them a long time to get off the ventilator, and we really have no idea of their functional capacity once they get off the ventilator. We have to do everything in our power to aggressively treat them to prevent them going onto the mechanical ventilator.
People that are presenting to the hospital are already a group of sickest patients. Remember, 80+% are being treated at home. So it's that 20% or even maybe even less that are sickest. So that's why it's so important to treat early. They've already been self-selected out to be the sickest of the patients being compared.
As you can see, you don't have to listen to me. Listen to these great doctors who have clearly laid out a plan to stop deaths from COVID-19 through early intervention. It's quite amazing that our system won't adopt this easy protocol. And it's clear to me that the reason it cannot be adopted is because they feel the need to have an expensive designer drug they can sell as a cure or treatment. It's not acceptable to have over-the-counter vitamins that can do the job. But anyway, that concludes our video, and in just a moment I'm going to wrap things up with my video. Bear with me for 1 minute.